Now we're going to see the damage to the pupils, or how we can distinguish a disease just looking at the pupils and pupillary reflex. So we will see Argyll-Robertson pupils. Argyll-Robertson pupils. Remember that this one we can see with systemic lupus erythematosus, diabetes mellitus, and syphilis, tertiary syphilis. We will see AD pupils seen on women and associated with decreasing the knee reflexes and some inflammatory diseases or infection diseases like viral. We will see Marcus Gunn pupils, Horner syndrome, and uncal hemorrhage. Here we will just review the pupils. So let's begin with the parasympathetic and sympathetic pathways, because these are essential on understanding anything that has to do with the pupils. So we have our preganglionic neuron, ganglion, postganglionic neuron. Let's see first the mid-thoracic pathway, and with this we will see Horner syndrome that we already saw in another video, but let's review quickly. So the neurotransmitter in the ganglion is going to be acetylcholine, receptor nicotinic type. Norepinephrine is going to be released to the target organ, and the receptor are alpha-1 adrenergic receptors. Remember, in the pupil we have the pupil, the iris. We have a muscle that is the radial muscle. This radial muscle is the one that is going to be innervated by the sympathetic pathway, and when it contracts, it's going to dilate the pupil. So, the first neuron is in the hypothalamus. The axon descends to the CA to T1 celospinal center of bulge. Then the second neuron, or preganglionic neuron, the axons are going to form the wide communicating ramus, and is going to pass through the sympathetic chain of the ganglia, and when it rises to the C2 level, superior cervical ganglion, passes the third neuron, postganglionic neuron, passes along the internal carotid through the cavernous sinus, and enters the orbit as the long ciliary muscle nerve. And it's this nerve that is going to innervate the radial muscle. That's going to dilate the pupil, and so this radial muscle has alpha-1 adrenergic receptors. Alright, now in Horner syndrome, we will see damage to any one of these neurons. The first neuron can be damaged with Pontine hemorrhage, Wellenberg syndrome, advanced syringomelia, and Brown-Sequard syndrome. The second neuron, the preganglionic neuron, can be damaged in pancreas tumor, because pancreas tumor compresses the stellate ganglion, and the stellate ganglion is part of the path that the axons of these preganglionic neurons takes in order to get to the superior cervical ganglion. Remember that the stellate ganglion is the fusion of inferior cervical ganglion and the T1 ganglion. And the third neuron can be damaged with internal carotid dissection. This postganglionic neuron also innervates the muscle of Mueller that aids in the elevation of the eyelid and some sweat glands of the face. So the patient with Horner syndrome presents with miosis, and hydrosis. Half of the face is not going to sweat, and mild ptosis. Mild because it's not the damage to the oculomotor nerve that decreases the innervation to the palpebral levator muscle. Alright, so this will be Horner syndrome, and this is how the pupil is going to look. Now let's see the parasympathetic innervation of the eye, and we will see with that all these pupils. So we begin with the Edinger-Westphal nucleus. The preganglionic neuron is the third oculomotor nerve, are the peripheral fibers of the third oculomotor nerve. Then the ciliary ganglion. here is acetylcholine, and then to the ciliary ganglion. Now the ciliary ganglion is the postganglionic neuron, and this postganglionic neuron can go to the ciliary muscle or to the constrictor pupillary sphincter. In this, we will go to this muscle that constricts the pupil. So here we have muscarinic type acetylcholine receptors, or we would go to the ciliary muscle. Here we have both ciliary muscles. Here the suspensory ligaments, here is the lens. When the ciliary muscles are contracted, the suspensory ligaments get relaxed, and so the lens has a more round shape. And we see near objects. This increases the refractive index of the lens. Now, first we can test this parasympathetic pathway doing accommodation. Accommodation is we will look at a near object and we will see this increase. Well, the patient would not have clear vision because it's doing accommodation, increasing the refractive index. Then the oculomotor nerve is going to adduct the eyes, and also by the parasympathetic pathway we will have meiosis. So one thing we can test is to see meiosis when we try to see a near object, and the other is to test meiosis when we do the pupillary light reflex. So we will put light on one eye. We already know the afferent limb is the optic nerve, pretectal nucleus, Edinger-Westphal nucleus, then ciliary ganglion. Ciliary ganglion, this is the third oculomotor nerve, releases acetylcholine to the ciliary ganglion, and then the postganglionic neuron goes to the constrictor of the pupillary sphincter. Now, pupils of Argyll-Robertson do not react to the pupillary reflex, but do to accommodation. And we will see this kind of pupils in lupus, diabetes mellitus, and syphilis. Now, are the pupils. These are pupils that react lightly to the pupillary reflex, but better to accommodation. So it's not a normal pupil because it has defective in the accommodation and pupillary reflex, but has more trouble in the pupillary reflex. Now, this is due to damage to the postganglionic neuron here at the ganglion, or a little bit later, but because there is damage to the postganglionic neuron, could not do accommodation and could not do meiosis. So there will be no meiosis nor on accommodation nor in pupillary light reflex, but it works on pupillary light reflex, that is less responsive to that. Marcus-Gunn pupils, these are seen in damage to the optic nerve. This is not a parasympathetic pathway nerve deficiency. This is just damage to the afferent limb that is due to the optic nerve. So we damage the optic nerve, and if we put light on this eye, there will be no constriction of the pupils. If we put light on this eye, there will be constriction of both pupils. If we then put light again on the affected eye, we will see that the pupils are dilating because there is no constriction anymore, and they are returning to the normal state because this eye is not perceiving light. This will be seen in anything that affects the optic nerve. Could be multiple sclerosis, could be optic neuritis, could be open glove injury, many things. In surgery, ophthalmologic surgery complication, many things. And they would present with Marcus-Gunn pupils, also called defective in the afferent limb of the pupillary reflex. And the uncal hemorrhage. Uncal hemorrhage is seen in epidural hematoma or subdural hematoma, etc. The point is that when we are compressing the third cranial nerve, and because we are compressing it, we are compressing the parasympathetic nerves first because those are on the periphery. So we would present, or the patient would present only with the damage to the parasympathetic pathway. Only that would be just no meiosis. So the patient, the pupil would be in a fixed dilated position. As time goes by, there will also be constriction of the fibers of the center that go to the extraocular muscles, and so the patient would have down and out vision due to the unopposed actions of the trochlear and abducent nerve. As time goes by, there will also be hemorrhage of the mesencephalus and pons. This is called direct hemorrhage, and because now there is also damage to the fourth cranial nerve or nucleus that is on the midbrain, and the abducent is on the pons, there will be now no opposition of any muscles of the extraocular muscles, so now the pupil is not going to be shifted to any position, so it would be just fixed and dilated. So now you know how to differentiate diseases only looking at the pupils and testing meiosis with the pupillary light reflex. And just remember that patients in pharmacologic medications, so how to distinguish adrenergic receptor agonists with antagonists of muscarinic receptors, because that's also we will see that reflected on the pupils of the patient. Remember that if we hit muscarinic receptors, we are also hitting accommodation. So a patient that is taking adrenergic receptor agonist would present the same way as taking muscarinic antagonist, but with muscarinic antagonist medication we will see cycloplegia, that is that the patient cannot see or has blurry vision seeing near objects, and patients taking muscarinic agonist present the same way as patients taking adrenergic antagonist, but patients taking muscarinic agonist would have trouble seeing far objects.